Foundation and NATCO. Actually, I'm very heartened to see the kind of number of registrations that we've had this class, and I'm hoping that all those who have registered will soon join. To me, this registration not just reflected an interest. Let's see what's happening. I think with the topic and the way it was explained, to me, it reflects a genuine interest and commitment on our part for our patients and their journeys. Yogita, are you doing speaker focus?
Okay, ma'am.
Because we all know, all of us who are working in this field, we know the reality is that not every patient will have a suitable donor. Some will wait for months, maybe years, and some, sadly and heartbreakingly, may never become candidates for transplants at all. So what do we do then? And I think this masterclass is about exploring these questions. It is about understanding how we continue to care and support and walk alongside our patients, even when transplantation is not immediate or ever possible. Because our role does not or should not end when transplant is no longer an option. In fact, that's the point. It should start evolving. And in that space, compassionate, informed, and dignified care becomes even more important than ever. And we really couldn't have asked for a better person to lead this discussion. I was very lucky to have met her, by chance met her at a recent visit to Manipal. And it is my privilege to introduce you Dr. Seema Rajesh Rao, who's with us today. A psychiatrist and palliative medicine specialist, she has spent years working closely with patients and families at some of their most vulnerable moments, guiding them with compassion, dignity, and deep understanding. She currently leads the Manipal Hospice and Respite Center and has been deeply involved in teaching and mentoring across India and internationally. What makes her presence especially meaningful for us is her experience in communication, grief, and end-of-life care, areas that we all know lie at the heart of organ donation and transplantation. And her insights will remind us that beyond system and protocols, it is empathy and human connection that truly make these program works. Just 2-3 instructions before I hand it over to Dr. Rao. Please keep yourself muted, being mindful of that. There will be an opportunity to unmute yourself later on and ask questions. There is an e-certificate for participation, and once Dr. Rao's presentation finishes, we will post a link, and it will take you a couple of seconds to give a feedback, and then your e-certificate will be automatically sent to you. Over to you, Dr. Rao.
Thank you. Thanks a lot, Pallavi. It's a pleasure to be here today. And as you rightly said, I think it is an area that needs much more, focus. So thank you so much for providing this opportunity. So let me sort of share my slides. Just give me a second. Is it visible?
Yes, it is very much.
With the speaker notes or without, like in a slideshow mode?
Yes, it's in a slideshow.
Great. So again, good evening, everyone. Thank you, Pallavi, and all of you for this opportunity. I'm going to talk about, integrating how we can integrate palliative care into the organ transplantation continuum journey. When we talk about transplantation, what we are talking about is the pinnacle of modern medicine, isn't it? But also it is important to know that the patient experience across this journey is actually far more complex, and it is important that we sort of focus on this aspect as well. So this session, I'll be talking about how we can improve the care, not just the outcomes, as we measure across the transplant continuum. So when you look at, in India, we face this unique challenge. I'm sure all of you are aware of the statistics of the gap that exists between the demand and the supply. And sometimes the waiting times are also very long. And there are a subset of patients who are waiting, but who may never receive a transplant at all, and they die during that waiting period as well. This context is critical because when we talk about palliative care here, what we are talking about is uncertainty, how to deal with that, especially in this continuum of care where uncertainty is not an exception but actually the norm. So that's the reason why palliative care becomes all the more important. In transplantation, much of our we sort of focus on the recipients, right? Get the organ and what happens forward. But we also have to understand we are dealing here with two very important cohorts. One who are losing, the other who are receiving. And integrating the care across this continuum is also equally important. The donor and their family, the recipient and the recipient family and their journeys. Both experiences are intensely emotional and are ethically very complex as well. And here, communication becomes extremely central, especially around expectations, uncertainty, ethical decision making, and compliance. All this gets impacted, and that is where I think the focus comes in primarily. So I will try to bring in some case examples. Like meet Ravi, 45 years old. He's waiting for a transplant. He's living with a progressive illness. He has a lot of fatigue. He has anxiety. There is no family donor, so he's dependent on getting the organ from outside, from someone, being eligible for it rather. He's waiting for his transplant and he's not sure whether he will survive the wait or not. Now, Ravi is not just a patient needing transplant, right? He has end-stage liver disease. He's also a father of two young children, and the wife is a homemaker. His needs go beyond just medical. He requires support. He requires communication. He needs to cope with this situation. And one of the things he says is, I want to live for my children, right? And I want to say as strong because he's the only earning member of that family as well. So his needs go beyond just the medical aspects, right? That he needs symptom relief from what he is experiencing, the fatigue, the pain that he is experiencing. He needs emotional support. Not only he, but his family as well. They need to cope with that worry, fear of losing him, uncertainty. He also needs to understand that the transplant may never happen in time. So preparation for death and dying is also a major part. Though we are talking all the time about survival, there is also another alternate path that is visible for him as well. And he needs to plan ahead for the future of his children, future of his wife, right? And there's a need for clear, honest communication for Ravi, right? So what we see is that it does not replace transplant. It supports Ravi and his family while they are waiting during this crucial period, right? Now let's look at another patient, Ahmed. Here he is not eligible for transplant. He has end-stage renal disease and he is not eligible for transplant. What now? Now, here the shift comes. Most of us are willing to involve palliative care at this point in time. The shift comes when cure is not possible. There is a lot of suffering, but care should not stop, even if you are not able to cure or offer anything. And that is where comfort, dignity, support, good end of life care comes in, management of symptoms, etc. The family, the emotional impact is always grief. There's a lot of grief. For the patient as well as the family, anticipatory grief, as we call it. There is anger coming in, there is fear, there may be spiritual distress that is coming in at this time, and the loss, multiple losses. It's not just one loss. They are coping with multiple losses, loss of role, loss of life, loss of future dreams, loss of functions in the body, right? And all this have to be managed. It's not just the transplant and the organ and the medical aspect of it. There are a multitude of symptoms that come behind it. And we need at this point in time, as he walks towards the end of life, it's important to walk with him as well as his family. And that is where we bring in that hope, right? Not abandon the patient because transplant is not possible, but provide appropriate end of life care, right? And then there is someone who has been lucky enough to receive a transplant, kidney transplant about a year ago, 48-year-old lady. Again, even after a successful transplant, her journey is not over. She now lives with fear of rejection, medication burden, financial stress, psychological adjustment to this new normal, which is her life. And this reminds us that success in medicine does not always translate to the well-being of the patient, right? What happens is that, things change, it evolves, the suffering changes a little bit, right? She also needs symptom relief. She also needs emotional support. She also needs coordination and support for her to understand what is happening with her life. So again, this is where the palliative care team can step in and support her. So these are three individuals, three trajectories in their journey, right? Which is very common, I'm sure. So when transplant is not possible, they are nearing end of life. They are experiencing advanced organ failure. And if you can see, this is about the symptoms that you see in cancer and in advanced organ failure, whether it is congestive heart failure, whether it's COPD or renal failure, even dementia or something, even AIDS as well. If you see, the symptoms are as much or as intense as what you see in cancer. Unfortunately, these groups never get palliative care. Many of the palliative care is sort of focused for oncology and cancer, but what we need to understand is patients, even when the transplant experiencing advanced organ failure, also have severe symptoms: pain, breathlessness, fatigue, difficulty eating, weight loss, even psychological sleep disturbance, depression, anxiety. All these are very common. They also have to undergo repeated hospitalization, and transition to end of life is never easy. And these patients, unfortunately, do not get the kind of support they need. So when we look at it, when transplant also does happen, you have pre-transplant, peri-transplant, and post-transplant phases. So suffering occurs through all this as well, right? It does not end with the transplant. The suffering transforms, though and helping patients and the families cope with the not only the medical aspect, the physical aspect of it, but also the psychological, social, and spiritual distress that arises out of this is extremely important. The complications that come, the uncertainty that come, the long-term treatment burden that they have to wear. And so the need for supportive care continues across whatever the phase they are in, actually. So when you look at it, if you look, all three groups, waiting, those not eligible, and the person post-transplant, they all live under the shadow of mortality, right? The trajectory differs and there is certain amount of risks. And this is constantly, it's like patient with cancer or constantly, even a survivor, or constantly lives with the fear of recurrence. Similarly, a patient who's undergone all the three subgroups also live with this constant shadow. The trajectory may be different, but the risk all remains the same. And that is why care must address not just the survival part of it, but how their experience, the lived experience of the patient and families who are living with this serious illness. And I think that is one of the most important aspect that we need to consider. And this is where palliative care comes in. We talk about serious health related suffering. That is a concept that we speak about, total pain, in palliative care, where we know, a disease does not just affect the individual's body. It affects their mind, affects their hopes, emotions, it affects their functionality, it affects their social standing, and the social practical aspects of it, financial, job related. And there is also spiritual questioning that comes in. Why did this happen? What wrong have I done to deserve this? Why is God punishing me like this? Right? Different stages, different realities, but one common thread across is health related suffering. And that is where palliative care comes in. We treat not only the disease, we treat the whole lived experience of having that disease, which encompasses all the four domains, what we call physical, psychological, social, and spiritual, not only of the patient, but also of the family. Coming to what palliative care is, right? It's a specialized medical, I think there is a lot of misconceptions about what palliative care is, which we will discuss a little bit further. But it's primarily a specialized medical care for people with life-limiting or life-threatening illness and their families. What does it do? It prevents and or reduces, alleviates suffering. The suffering could be physical, suffering could be psychological, suffering could be social or spiritual. Right? It improves the quality of life. And not only the quality of life, but if cure is no longer possible, it also improves the quality of death as well. How does it do it? Identifying the triggers very early, assessing all the four domains, not only the physical, but all the four domains, and treating. Okay, pharmacologically as well as non-pharmacologically, the symptoms, pain, breathlessness, fatigue, etc. One thing palliative medicine doesn't do is treat the disease per se. And it begins at the diagnosis, continues throughout the course of the illness, provides good end-of-life care, and continues beyond the death of the patient into the bereavement period as well. So the trajectory of palliative care is huge. It begins at the diagnosis of a serious illness, and throughout it walks concurrently with the treating team to alleviate the suffering. Where the treating team focuses on the disease aspect of it, the palliative care team focuses on the suffering aspect of it, and they walk concurrently. And towards the end, when cure is no longer possible, the role of palliative care increases and it extends beyond the death of the patient because it looks after both the patient as well as the caregiver. The biggest misconception that is there about palliative care is that palliative care is only end of life care or terminal care. So I want you to understand that difference. So you can start, it is not dependent upon the stage of the disease, and palliative care can be provided concurrently with disease modifying treatments. So I generally talk about Diwar here. You have Amitabh Bachchan, you have Shashi Kapoor, right? Both were excellent actors, right? And can we think of that movie without either of them? Absolutely not. But who was the hero in that? Amitabh Bachchan was the hero and Sashi Kapoor was a supporting role, isn't it? So it's similar to that, It is the treating team, the oncology team, probably the transplant team would be the primary actor. We come in as supportive actors to look after the other aspects. So that's what palliative care is. Coming to this confusion about palliative care, what is hospice? What is end of life care, right? So hospice care, end of life care, terminal care are all part of palliative care. While palliative care begins at the diagnosis, hospice care begins when the disease becomes incurable, when the patient is at end of life. Now, when do we say patient is end of life? There are certain medical parameters, whether it is for cardiac failure, whether it is for cancer, whether it is for renal failure, whether it's for dementia, whether it is for stroke, whether it is for Parkinson's disease. For every chronic illness, there is a point, there is a criteria that tells you when is this patient nearing end of life. Medical criteria, medical signs and symptoms are there that we look at. So generally the period of 6 months to 1 year is considered as the last 6 months to 1 year of that person's life is considered as end of life. As per ICMR does not defines end of life as that part of disease management when the focus of treating the patient shifts from curing the disease to providing comfort. So ICMR does not give us an precise timeline for starting end of life care. But in UK they look at 6 months, in no, I'm sorry, about 1 year in UK, and in US they look at 6 months as potentially end of life period where hospice care can be started. Now hospice care, while the treatment for the disease continues, probably it is, you've reached a point where it is not changing the or making any improvement in the quality of life of the patient. Here the emotional, social, spiritual aspects become more important, and that is when we start hospice care. And palliative care, I said, begins at the diagnosis. Terminal care is that time, maybe the last 1 week of a patient's life, when we know death is imminent, patient is actually dying, there are signs and symptoms which are very visible of uh, death visible, like the peripheries are cold, pulse has slowed down, or patient is tachycardic, breathing has become irregular, patient is comatose, not responding very well, oral intake has reduced, are primarily bedbound. So the patient is actively dying, and their only comfort is we look at only providing comfort, supporting the family through this phase. But the problem what we have is we are often brought in that phase of terminal care when patients are imminently dying. And then there is nothing too much that we can do at that point in time, because that would be if we are able to recognize the need for palliative care earlier and refer earlier, then it would help in providing good quality of life and helping the patient live as well as possible until the last moment. So what this slide outlines is specifically about the multiple dimensions of palliative care. You have the physical pain and symptoms are taken care of. You look at the functionality, improving the functionality as much as possible. You look at wound management if the patient has wounds. You look at the disease management, which is primarily looked up by the primary treating team. You communicate with the primary team to provide adequate disease management of comorbidities. The palliative care looks at pain, symptom management, the functionality, nursing care, prevention of bed sores, etc. The psychological aspect is a major part of what the palliative care team looks at, looking at the depression, anxiety, emotions, helping the individual with coping, right? Dignity aspects, providing helping them deal with their own emotions. The social aspects, right? What are the cultural belief systems of this patient and their family? How can we integrate it into our care? What are the roles and relationships that work for the patient and do not work for the patient? Explaining, looking at the legal aspects in case there are some unfinished businesses, helping them, and then caregiver empowerment, helping the caregivers understand how to take care of the patient. The spiritual aspects. One of the important aspect questions that most of a patient asks is, why me? What wrong have I done to receive this? Why did God punish me? Exploring these aspects. Palliative care providers are trained in all these aspects, and the practical aspects of day-to-day care. This is a big part of the stress that the families carry. Where do they go for treatment? Whom should they contact? How do they navigate the healthcare system? This is also a big source of health related suffering. So these are aspects also that we need to take care of. And I want to bring your special attention to the end of life care and death management, because this is often misunderstood. Death management is not just about grief and death. It starts much earlier, even while the patient is alive, even when curative or life prolonging treatments are going on. It is, one path is cure. The second path is also complications and dying. So these both conversations have to be kept open. It involves planning, preparing, and preserving agency. Giving patients the correct understanding of where they are going helps them to have some sense of control over their lives. Helping them, patients and families understand what lies ahead. Helping them to make decisions about their care, what we call as advanced care planning. Allowing them to express preferences. I have patients who have told me, I don't want to go on to the ICU. I don't want to go into the ventilator. If death happens, I want to die at home. In fact, during COVID period, we have seen had so many elders coming and telling us that please don't put us on the ventilator. Use the ventilator for someone, for the younger patient, voluntarily refusing to be put on the ventilator. And then we had to document these, because otherwise by default they would go on to the ventilator. Many of them did survive, of course, but that was the conversations that we had. But we should give them that opportunity to have those conversations, express the preferences, where they want to be, whom they want around them, what matters most to them when the end of life comes in. It's about maintaining control and dignity in a situation that is uncontrollable, right? Because the disease is not under their control. For families, it reduces uncertainty and conflict. You would have seen one person wants to donate, and one family member is all okay for organ donation. Another family member is, opposing it. So at that critical moment when decisions have to be made, there is confusion, there is conflict between family members, between siblings. Suppose these conversations had happened earlier, right? It would have reduced that amount of, for patients, their sense of clarity and peace is there, and it does not take away hope. Many of the time we fear to have these conversations because we think, okay, if we talk about death and dying, we are taking away hope, right? But it does not take away hope. It redefines the hope. From cure, if cure is not possible, we will provide control of the disease. When control is not possible, we will provide comfort. We will prepare you. We will provide meaning and purpose in life. Even in transplant settings, when you are actively pursuing cure, there must be space to prepare for the possibility that things may not go as planned. And this is what good communication, good palliative care does. It allows us to care for both possibilities simultaneously. It's not, one or the other. There are both possibilities because it is a serious illness. But how do we navigate those conversations? That is the skill that we need to learn without giving realistic hope, without, false reassurances, false expectations, and not giving hope at all, right? Those skills are something that we need to learn when we have these conversations. So, for donation to happen well, right? Death also should happen well. When they are prepared, when you talk, about death and dying, if you're able to identify, of course, sudden deaths, we may not be able to, have this, but the conversations should start way earlier. In fact, a person like me, I'm healthy, right? I can always, the living will is something that is very, which has come into, has been legalized currently. I can decide whether I want to be put on a ventilator, whether I don't want to be put into a I don't DNR, I don't want to be resuscitated, I don't want to be put on a ventilator. I can make a living will in case I fall seriously ill. I can decide what are the interventions I want, what are the interventions I don't want. Integrating with them when we have these conversations, also including organ donation in that conversation is possibly one way to go. It's, so when we look at the donor journey, we need to look at, it's also important to look at palliative care for the donors and incorporating these conversations in advanced care planning. I think this also will help us tide over that gap between demand and supply that we see. So to put it together, across the transplant continuum, we are seeing high burden of suffering. Pre-transplant, during the listing and waiting period, during the surgery, post-transplant, and when not eligible for transplant. Throughout this continuum, we see high burden of suffering. There are complex ethic decisions that need to be made. There is a lot of uncertainty. And what comes out is a clear need for integrated palliative care, right? And it should not be an afterthought, it should be integrated early, systematically as part of standard care. We need to start early. Now, I sort of have looked at what is the need and what we do in palliative care. What I would like to do is, again, discuss is what is the evidence that is there to say about palliative care integration in organ transplantation. I looked through a lot of papers, and unfortunately, most of them are coming from the West. We have hardly anything, maybe a commentary or so from our setting. But what I found was mostly from the West. But there also, what we are seeing is, very few literature about this space. Many of the papers are 24, 25, 26, what I have seen. Okay. So early inpatient palliative care in hemopoietic stem cells transplant. Okay. Here, this was a very nice study which was done where palliative care was integrated very early during the transplant, right? And ongoing support through the transplant hospitalization, and afterwards also they continued. What did they see? They said improved quality of life was the first parameter. Reduced psychological distress. The symptom control was much better. Management of pain, management of anxiety, etc. was much better. And there was enhanced patient-centered care was provided. There was patients and families coped better with the transplant. So early inpatient palliative care is of high value. Okay, and it significantly improved the quality of life of the patient as well as the caregivers. It reduced distress and the outcomes were much better comparatively. Now you have, for hemopoietic HSCT, you have this evidence available. And this is one of the strongest evidence bases that we have. Now look at this was for the solid transplant patient. There was an RCT conducted. Okay, palliative care utilization and timing for patients undergoing solid organ transplantation. Less than 10% of the patient were referred to palliative care. The majority went without any support. And when did they refer? Not during the pre-transplant and the waitlist period. Okay, they were rarely involved. It was crisis referral during the transplant, or probably when there is a complication, when they are in the ICU, when there is an organ graft failure has happened, then they get referred to palliative care just before, at the end of life. So if you see, the orange and the red areas are where they get referred, right? So there is minimal. So what we need to do is start right here in the pre-transplant evaluation period itself, because there are going to be symptoms. They are going to be experiencing advanced organ failure. At that point, if you need to be involved, right? And palliative care is underutilized, right? Which is the norm everywhere, whether it is cancer, whether it is non-cancer. We know that it has some benefit, but referrals, it is equated to actually end of life. Because of that, people don't bring palliative care in earlier. But I hope this session sort of clears the misconceptions around palliative care. So what do guidelines say? As usual, almost all the guidelines tells us we need to integrate, right? Whether it is WHO, whether it's ASCO or European Society for Organ Transplantation, HPNA, all these guidelines. But in India, we don't have. Am I audible? Okay. Yeah. Because there was a electricity fluctuation at home, so I thought maybe I had lost connection. Okay. So guidelines increasingly recommend early integration. They tell us communication support is needed, advanced planning need to be started, but implementation is still very limited. Not only in India, also in the developed world where there is good palliative care integration, still even there, though the message is very consistent, the implementation of that message is very fragmented. In India, there is no transplant specific national guidelines for palliative care integration. Maybe something we can all work on. We can look at the guidelines from the critical care medicine when they talk about end of life care. In fact, Manipal is doing a huge study on how to integrate ICMR multicentric study is happening. About how to integrate palliative care and improve outcomes in the ICU. So this is something that needs to be worked on for Indian patients as well. So how look at, I was thinking about how do we integrate? Maybe, start with a roadmap. Currently, what we see is fragmented systems. what we know in India, what is happening, right? There is no well integration. It's not only in this field, palliative care actually is quite fragmented all over. The very few centers have achieved a robust integration within oncology, within non-oncology services, right? So that is something that we need to work on. Also, the late referrals, which is the norm. In fact, when I was working in Tata Memorial Hospital, I remember patients would be referred, and from one OPD to the other, by the time they came to us into our OPD, they would be gasping, right? And we are just, we managing the death there and writing the death certificate. So, that late is how the referrals come in. And there is limited awareness. I think one of the biggest aspect of what this webinar or this what it can do is raise this awareness and help people understand, to what we need to do to serve our patients better. And then the necessary changes first has to come within us. You don't have to have a specialist palliative care team available, right? All If all of you get trained in the palliative care approach, right, that itself would be the first step. The clinicians, there are a lot of training programs in palliative care. The Indian Association of Palliative Care conducts training program for nurses, for doctors, for psychologists, for social workers, for pharmacists, for volunteers. These are all online training programs conducted by the national body. And it's sort of, these are things that you can get yourself trained in. So the existing group of people working can themselves improve their competency in providing palliative care. Hardly 10 to 20% of patients will have complex issues. Rest all can be managed as the primary and the generalist level. We talk about 3 levels of care. The palliative care approach, which every person should know. Even the caregiver should know about the palliative care approach. Okay, this is something that you need to learn. Then the generalist level, where doctors, trained healthcare professionals understand certain things about palliative care and manage the basic issues themselves. And above that comes a specialist level, which manages complex issues, right? So majority, 70% of the problems can be sorted at the primary and the generalist level. But it is the change in attitude that matters. So necessary changes that needs first is capacity building. It's about knowing communication skills. How do you talk to patients? How do you talk to patients without taking away hope or without giving unnatural, unrealistic hope? How do you explore their feelings? How do you explore distress? So communication is a big aspect of what we do. Symptom management is the other big aspect. Learning how to take care of pain adequately, nausea, vomiting. How do we, depression, anxiety, how do we manage these symptoms in a holistic manner? How do we look at if patients are nearing end of life, how do we manage that? There are a lot of therapies that we do at end of life. It's about life review, memory making, legacy making. These are all activities that even a volunteers can learn to support families who never reach that transplant journey at all. And then comes once the awareness builds in, capacity is built in, comes the system level integration. Integrating, as I told, in advanced care planning, the talk about organ donation into advanced care planning, something we can actively work on actually between, looking at policy frameworks. How do we create? How do we integrate with ICU palliative care? And how do we, replicate this across all systems? These are something that we can look, and also research priorities. I think, when I was going through the articles for today's talk, I realized we don't have much research from our side regarding integration. Maybe it's time to plan something, right? So I hope this multiple seeds are sown in this, with so many of you. I think more than 30, 35 of you last when I saw are there. So maybe each one of you can be an ambassador of how you take, which part of it you will focus on. This is where we must move next. It's not just, when we talk about organ transplantation, it's not just about saving lives, right? It's about caring for people, whether they live, they are waiting, or, they have reached that end of life phase. It's about caring for them and their families as well. And we have to look at both the cohorts, the ones who are giving the organ and their families, and one who are receiving them at then. What we know is that the multi-dimensional suffering exists across all these trajectories. And that is where we, palliative care, helps. So it improves quality of life, it improves quality of um, uh, death as well. It helps to take decisions. Decision making is empowering patients and families to make those decisions, providing dignity at that point where it matters the most. And our country needs more of this integrated model of care. We are all working in silos. We need to come together. If we need to improve, we need to bring all the players together to provide holistic care. And that is something that palliative care does. It's a multi-dimensional approach. It's not a work of one person. It's a work of a team. It's a multidisciplinary team. It's about collaboration. It's about communication. It's about compassion. Okay. It reminds us that we have to honor the journey on both sides of the transplant. So if I have to, reflect, give you a pause for reflection, just think and ask, how will you integrate the palliative care approach into your own practice? Right? At what stage, with whom, in what form? Right? And integration begins with individuals before it becomes a system-wise integration. So I think they say, small drops form the ocean. Each one of us, if we pause and reflect and see what skill sets do I need to acquire in the area that I am working to achieve better integration and be able to take better care of my patient, and that integration will start at an individual level before it moves on to a much higher space, right? Yeah. This is a video. I hope I can play that video. It's about our model at Manipal Hospice and Respite Center, an example of how structured, compassionate care can be delivered. Can you see here?
Yes, we can.
ಕೆಲವರಿಗೆ ನಾವು ಮ್ಯೂಸಿಕ್ ಕೇಳ್ಬೇಕು, ಇನ್ನು ಮನೆಯವರನ್ನು ಭೇಟಿ ಆಗ್ಬೇಕು. ಮಗು ಒಂದಿತ್ತು 8 years ಹುಡುಗ ಸಮೋಸ ತಿನ್ಬೇಕು, ಪಟಾಕಿ ಬಿಡ್ಬೇಕು, ಹಾಗೇನಂತ. Lot of uncompleted works or financial wills.
A sense of completion. A desire to experience the best things of life again. A simple touch of the loved one. A proper stitch. A better painkiller. A cleaner wound. Ability to speak for just a few more days. A fresh breath of air. Sunlight. A simple acknowledgement of who they are and have always been. One last time. Many things matter for a person to live their days to the fullest, especially when it's their last few.
There is a huge need for palliative care in India. It is estimated that around 7 to 10 million people need palliative care. But unfortunately, less than 4% who need it actually receive it.
Manipal Hospice and Respite Center was started with a simple philosophy that when the days are short, it's not about giving up. It's about giving back. Dignity, love, and presence. One of the largest in the region and free of cost to patients. This is the only hospice and respite center affiliated to a university and a medical college hospital.
We improve the quality of life of the patient as well as the family members. It looks after not only the physical symptoms of the patient, but also the psychological aspects, the social aspect, and the spiritual support as well. It's a holistic care.
In spite of comprehensive care and support facilities, this feels more like home, calm, expansive, deeply personal, and in oneness with nature. Care here is constant and capable. 24/7 medical support and nursing by your side. IV, oxygen, and evidence-based relief for pain and difficult symptoms. Skilled dressing for wounds that refuse to heal. And if acute care is needed, doctors from Kasturba Hospital are just minutes away.
When we look at hospice care, what we are talking about is essentially end of life care. When we talk about respite care, it is for patients at any stage of the disease. They are not necessarily at end of life. It is a short-term admission where the physical symptoms are taken care of. And also it provides us with an opportunity to empower the caregivers on how to take care of the patients. And this center is both for hospice care as well as for respite care.
It's more than medicines or machines. A therapy block hums with small victories, one steadier step than yesterday, one daily task made a bit easier again, someone empowered to speak again or have a first comfortable sip. Therapeutic music to remind the heart that it can still open.
ಎಂದ ಲೈಫ್ ಆಗುವಾಗ ಅವರಿಗೆ ಏನ್ ಮಾಡ್ಬೇಕಂತ ಗೊತ್ತಾಗುದಿಲ್ಲ. ಅವ್ರು ಸಹ ಬರುವಾಗ ಹಾಗೆ ಟ್ರಾಲಿಯಲ್ಲಿ ಇದ್ದಿದ್ದು ತಕೊಳ್ಳಿಕ್ಕೆಲ್ಲ ಕೇಳ್ತಿರ್ಲಿಲ್ಲ, ಏನಾದ್ರು ಟ್ಯಾಬ್ಲೆಟ್ಸ್ ಎಲ್ಲ ಕೊಟ್ರೆ ಬೇಡ. ಈಗ ಮೊನ್ನೆ ಮನೆಗೆ ಹೋಗ್ಬೇಕಂದ್ರೆ ನಡ್ಕೊಂಡೇ ಹೋಗಿದ್ದಾರೆ. ಅವರು ಖುಷಿಯಾಗಿ ಹೋಗಿದ್ದಾರೆ. ಅದು ತುಂಬಾ ನೆನೆಸಿ ಖುಷಿ ಆಗ್ತದೆ ನಮ್ಗೆ.
When we are actually treating the disease, we are adding days to their lives. But as a palliative care physician, when I treat a person, I actually add life to their days.
ಇನ್ನು ಮನೆಯವರನ್ನು ಭೇಟಿ ಆಗ್ಬೇಕು, ನನ್ನ ಮಗ ಬರ್ಬೇಕು, ಆ ತರ ಫೀಲಿಂಗ್ಸ್ ಇರ್ತದೆ.
ಚಿಂಟಿಗೆ ಮೊಮ್ಮಕ್ಕಳನ್ನ ನೋಡ್ಬೇಕಂತ ಅನಿಸ್ತಾ ಇದ್ದ. ನಾವ್ ಅದಕ್ಕೆ ಸಮಾಧಾನ ಹೇಳ್ತೇವೆ, ಅವರಿಗೆ ಮಾತಾಡ್ತಾರೆ, ಅವ್ರು ಬರ್ತಾರೆ, ಹಾಗೆ ಅಂತೆಲ್ಲ ಹೇಳ್ತೇವೆ.
No amount of care can match a family's presence. Visiting families are not measured by a clock. Loved ones can stay, lend a hand, or simply sit in the same sunlight. Presence becomes medicine. Touch becomes reassurance. Time itself becomes treatment. This is a place for finishing the unfinished. A legacy etched in a family tree. A last birthday candle. Another best moment to relive. A recipe passed from a mother's memory to a daughter's hands. A festival marked quietly, exactly the way home would have done it. Counselors help hold the hard words. And when the moment comes, they are beside those who grieve, offering gentle bereavement support so sorrow is carried and not shouldered alone.
A loss of a person cannot be replaced. Anything, any word said, anybody cannot replace a loss of a person in a family's life. But always we can modulate our support systems to help them tide over the crisis.
This is Manipal Hospice and Respite Center, a home away from home with hospital-grade care, where dignity is restored, families are reunited, and ordinary days are made beautiful to live life to the fullest for that one last time.
It's so beautiful.
Thank you for listening. I'll
Thank you
stop
for
my
this.
slide share.
Yeah.
Yeah.
Venkatesh, you can put the link for feedback and certificate at this point of time. Thank you for that presentation. That was absolutely beautiful. So before I met you actually, and since then, in the months leading up to this, in the weeks leading up to this masterclass, my understanding of palliative care was also, that it is about helping people die peacefully, and in that understanding, a standalone hospice fitted. Now you have brought in a very different understanding of what palliative care could mean. So then how do we do this in places like this where we may not have a hospice like yours? Do hospitals have palliative care departments? How does this work, and who does this role is a question that I would like to begin on before other people.
Yeah. So I think, see, the primary palliative care approach is anybody can incorporate within their specialty. If it is, every hospital has a doctor, right? So the doctors also can get trained in palliative care. right? See, for example, the physicians, when they treat a disease, initially it's about looking after curing the disease, managing the disease. At one point, they also know that disease cannot be managed adequately. The disease has become incurable. At that point, focus on the symptoms as well when you're managing the disease. Most of the time, what happens, the focus is only on the disease, managing and controlling the disease, that symptoms are not managed adequately. So that is where the suffering comes in. And having that holistic approach to care, I think, is where we can start. I'm sure, as you rightly said, not many institutes have palliative care departments, though it is improving quite a bit in the last 5 to 7 years. A lot of institutes have started, but it's also important that within the system itself, teams, you have a person who's trained in palliative care who can bring in this perspective.
Are there questions from the audience? Yeah, Shrishti, you can unmute yourself.
Hi, ma'am. So basically, my question was like, how exactly do we need to show like compassion and empathy in such a way that, when the end of the life term comes, we are able to not only counsel them, but ensure that, they are in the right path of grieving.
Okay. So, I think it's important to understand that there is a difference between empathy and compassion, though we use it intertwined, right?
Interchangeable.
Yeah. So empathy is about, being able to understand the perspective of another, right? What they are going through. Compassion is empathy plus action, normally I say. Okay. So what are you going to do to relieve that suffering? It could be something very simple, right? It's not very complicated. It's only requires an attitude that sort of, helps us to look beyond the disease. A simple example I'll give you. It's about one of our patients. Her husband was dying, right? And she was sitting outside, and she's young mother, right? Sitting and crying and sobbing loudly. What would you assume? You would assume that she is sort of crying because her husband was dying. For the past 1.5 to 2 months, we've been talking to her about the death of her husband, and she was more or less prepared for it. So one of the, when we started exploring what was it that triggered this grief, this crying, she said the thought that I know that he's dying, but right now I don't have the money to take him back to my home after death. It was something as simple as that. The fact that he was dying was the source of her grief, enormous grief that she was going through. But what broke the camel's back was the fact that she didn't have that 5,000 rupees to take him back to her hometown. Right? So that was something that could be easily managed, isn't it? It's a very tangible thing, right? That was the hope that we could give her. So suffering does not necessarily come from a disease itself. Like if you ask patients who are dying, if you ask them, one of the things they will tell you is, I'm not scared of dying, right? It's okay. All of us have to die at one point or the other. What will happen to my wife? What will happen to my children? So being able to address these questions, we may not be able to all the time help them with money or whatever, but helping them, ventilate these aspects and seeing what could be done at that point in time itself. So is one of the ways that you can provide compassionate care. Coming to doctors, I will tell you another way. We had a patient who had esophageal cancer and had undergone stenting, right? And they had put a stent in the esophagus, right? And she had just come back from home, and there was a tablet that was given for pain, paracetamol, Dolo, okay? And you all have had Dolo, right? You know how big the tablet is? Correct? Have you put it in your tongue? How bitter it is, right? What had happened was they were crushing the tablet, mixing it with honey and giving. It was so bitter, she was vomiting. Now she's just post-surgery. The stent was there, and she had gotten discharged and come home on dolo for pain or whatever, and she was vomiting, retching, and the pain was increasing. What would a compassionate doctor do? We have pediatric syrup, right? Calpol syrup is there, which is similar to dolo, which is very sweet, right? We had to give her 2 bottles instead of 1 tablet, but she could swallow it easier. Correct? It's just an attitude of looking at it from a different angle. The same medicine given in a different form,
Different form.
right? So, yeah. So compassion can't be taught. We have to look for it and bring it in our actions, right? So if I have to teach you compassionate care, I may not succeed, right? You look at your patients, you see what, try to understand where they're coming from and try to sort out their small problems depending on your field of competence. If you are a doctor with appropriate medications, if you are a nurse with appropriate care that you're providing, if you are a psychologist with the appropriate counseling that you're giving, if you are a social worker with an appropriate, whatever your competency is, look how you can make things better for the person.
Hemal, you have a question?
Ma'am, I have one question. I'm Dr. Shreya Shukla. Am I audible?
Yeah,
Yeah.
you're audible.
So my question is whether we need to take consent to transfer or rather to take a patient from active treatment to a palliative care. Whether we need to take a consent. Number two, who takes that initiative to decide that now the active treatment would stop or will be reduced and the patient will be put on gradually onto the palliative care completely.
Okay. So I think consent is not needed. Why do you need consent? Because this is a different type of care that you are giving. Do you take consent to provide oncology care, or do you take consent if the patient comes to you? If you're a nephrologist and the patient comes to you, do you take consent to provide care? No,
No,
right?
ma'am, sorry to interrupt you.
Yeah.
My concern was shifting the patient from active treatment to palliative treatment. So you rightly said that active treatment adds life to days, and in this we add, sorry, it's the other way. But the concern is some relatives may take that objection, like that we should continue the active treatment, something like that.
So what I said was palliative care starts concurrently with this thing. You can continue your active treatment and introduce palliative care for management of symptoms or suffering, right? What you're trying to ask me is probably when you shift a patient from a hospital to a hospice, whether you need to take consent. Is that what you're asking?
Yeah.
Right?
Yeah.
Yeah. So at that point, see, hospice care is probably, so when you shift, your place of care changes from an active hospital to a hospice. Yes, at that point of time, DNR, the end of life care, what we do, DNR, do not ventilate, do not intubate, those consents are taken, right? But for starting palliative care, you don't need consent.
There is no need to.
Because
Thank
it
you.
is integrated in a hospital system, and it's another part of the type of medical
Treatment
care
itself.
that you're medical care that you're providing.
Treatment.
Yeah, but if you're going to shift to a hospice, as like us, it's a separate building, right? So in the Department of Palliative Medicine and Supportive Care, which is within the hospital, we don't take consent. Okay, but DNR ke liye, if it is required to shift to the hospice, we do take a consent. I hope I've clarified that doubt.
Yeah.
Hemal, you were asking something?
Yeah. Thank you, ma'am. Thank you, ma'am.
Hemal, you want to ask your question?
Thank you, Dr. Seema, for such a nice, clear talk. I've been really waiting for this talk for many years, and finally Pallavi has found you out. Thank you so much. There are a few things that came into my mind. One was if the doctors, refer to the patient right from the start to a palliative caregiver or a palliative team, but if they do not, and the transplant coordinator does know that they need something. Okay, if the transplant coordinator has taken a palliative care fellowship or something like that and knows more than the doctor, then can they do that? Is it allowed to do that? What is the status of a transplant coordinator in this thing? And how can we get more doctors to refer to the patient at the start itself? What can we do as transplant coordinators?
I think one of the things is, awareness. See, all doctors want what is good for their patient. Very few doctors actually would, not want to do what is good for their patient. Only thing is the misconceptions probably of thinking that it is only end of life, or some of them are not aware about palliative care and the extent of services that a palliative care provides. Right? See, initially when palliative care was started, right, primary focus was on end of life. So it got equated with end of life care. That misconception many of us even now carry. In 2010, Temel et al. In lung cancer did a study which showed improved survival even when it was integrated earlier, because complex decisions were made. Patient was more informed. They were able to make more decisions, right? And after that, the concept of palliative care changed to begin at the diagnosis itself. So I think one is to create awareness among your team. If you have gotten trained in palliative care, bring the learnings in and create awareness. Have small seminars, webinars, to bring in that concept in. Two, informing the patient. Okay, one of the roles, what you do is also information sharing, isn't it?
Yeah.
Empowering the patients to make those decisions. That is also something that you can do. No harm in doing it. Of course, when you work within a team, it's important to keep the team dynamics in mind, and take everyone along rather than, work in cross purposes. So I think that is extremely important.
Another question I had was, when we take a patient in any palliative care center or a respite care, does the health insurance cover the expenses? You are having a free thing, but does the health insurance cover these things? And if there is an expense, how does the family, deal with those expenses?
So there are different ways in which we handle. Many of the palliative care centers offer free. Okay. But there is also some, there are certain codes which in Ayushman Bharat, etc., which are covered for palliative care procedures. Okay, number one. Number two, I think ESIS and the army, those they have incorporated under their insurance, they have incorporated palliative care.
So like CGHS, we provide that.
I think that is there, but generally most of the insurance do not cover. So that is one aspect. Second, palliative care is not very expensive. Okay, there are no major procedures, no ICU. It's done in the ward, and it's the day-to-day medications that you use to manage. Right? So it's not a very expensive this thing, and 80% of the palliative care centers are free of cost.
Thank you.
Question, Dr. Rao. Say if a patient, if someone is taking treatment and it's decided that he or she is not a suitable candidate for a transplant, how do we prevent that person from just falling through the system? Because then he's not coming for any active treatment or whatever. So unless, I don't understand, how do we integrate that unless there's a hospice kind of a situation? It's something that I'm unable to
visualize. Okay, so you have home care palliative care teams as well. Many places do have home care teams. So one of the things is, look at the wherever areas you are in, find out where are the nearest palliative care centers, right? Some
Is it me or is it Dr. Rao?
Dr. Rao looks like it.
Now we can hear you. We couldn't all this while. Hello,
Hello.
Dr. Rao? We can't hear you. Oh, oh, sure. Let's join back.
Hello. Am I audible now?
Yeah, you can. Now we have you.
The call dropped in between. Extremely sorry for that.
No, that's all right.
So where was I?
We were talking about home-based palliative.
Home-based, yeah. So I think one of the things is there are home-based palliative care available. In case you find this person is not eligible for any of these, transplant, etc., look at and refer to the nearest palliative care team that is there, whether it is home care or whether it is in a nearby hospital or whether there is a hospice. eh, um, and actually now there is a lot of thrust from the government also to establish palliative care programs in the district level, district hospitals as well. So these are all areas that you could tap to depending upon where you are.
Okay, I think we'll take just one last question, which Poonam has brought up, is that we talk about palliative care for patients. What about the caregivers?
So I told that this is
That won't be
palliative
called
care.
palliative care, but
Yeah.
it's part of.
Yeah, caregivers, it's not only for the patient, but also for the caregivers. And that is why it extends beyond the death of the patient into the bereavement period as well. So, grief counseling, bereavement support, identifying those who are at risk for complicated bereavement, these are all part of the work that we do in palliative care. So, caregivers, our unit of care is patient and the family, right? It's not just the patient.
Okay. Any other questions before we let Dr. Rao go? I think you've given us a lot of.
Pallavi, there is Mrs. Lalita has said something in the chat.
Okay, I am not able because I joined that chat history is erased for me.
It says whether it is transplant care or palliative care, the healthcare professionals go through a burnout. How do you deal with this in palliative care?
Okay. So I think that is a very interesting question. It's a high emotionally intense arena that we work in. So one of the things that we do is also self-care. Okay, debrief and self-care. So for example, we have started something called as Samvad. Okay, it is a debrief session for doctors, nurses, volunteers, physiotherapists, etc. We once a month we all join together and debrief in terms of we have a psychologist who comes and does the debriefing. We talk about our emotions. We talk about how difficult the difficult cases we have seen. We talk about the ethical and moral conflicts that we are facing. We talk about our helplessness. Self-care is an important aspect of our training, right? Because we work in high voltage environment where suffering is the norm, right? And helplessness, 80% of the time I myself feel very helpless about things, why I'm, so it's very, very common. But self-care debriefing is extremely important, and having personal self-care techniques where you take care of yourself, you handle your emotions, you take your hobbies, you don't carry your work back home. Learn techniques to handle all this. And that is, I write. My own personal technique is journaling, and I write poetry. So even I've published also about 50 poems, what I have written. So that is how I bring out my pain. So I think these are important aspects of what we do.
So what I'm really gathering here is that as coordinators, especially, of course, there are a lot of doctors here, we may not have the skills or the right training to handle very strong issues around palliative care. But I think the trick is to be aware that there could be a requirement and to to have resources to connect to, and at least be cognizant that there could be more, I think, because in fact, I have a talk tomorrow. I was asked to comment on this question. The transplant coordinators or grief counselors, what does India need? And one of the things that I'm going to say is that as transplant coordinators, sometimes we are not really trained to handle grief, and it is a different skill set, which requires training and, as you said, aptitude. But the idea of this session was to understand that there could be requirements more than just what we are usually trained to look at. Dr. Seth has joined us. Dr. Seth, did you just join us? You missed a
Yes,
very good session.
I've been listening. I had a lot of patience. Wonderful session. Nice to see Dr. Seema. And can I have a quick question, Pallavi?
Yeah, sure.
Yeah. So there was a little dichotomy that I've been pointing out last time also when we met Dr. Seema, that if I have done an advance directive, then one is not supposed to be put on ventilator, etc. And if I have pledged my organs also, then how do you resolve this conflict where I want to donate my organs, but for that I have to be on a ventilator, and on the other side I've signed an advance directive. So if somebody signs up for both these things, how do you think we can rectify this?
So I think it was there in one of my slides that ACP may we incorporate this organ donation aspect. I think that is the discussion that is important, right? In that case, if I'm an organ donor, I automatically go on because my legacy is that, isn't it? That I am sort of pledging my organ to somebody to continue that legacy, my meaning making and purpose. So probably that is one change that we need to bring in our
Living well and all of that.
living will and all of that. And that is where the system level integration we need to bring in. And we are doing ACP sort of, we are restructuring it a little bit based on the guideline. And I'm sure at that point in time, this is something that we can keep in mind.
So we train transplant coordinators.
Thank you.
We have a very comprehensive module for training, and I don't know if the content allows very full-fledged training on palliative, but just introducing it as a concept is something we would like to do. Poonam is here. I don't think Sujata has joined, and this is something we can discuss, and with your talk could go in as one.
Sujata ma'am is there. She is there
Sujata
with
is there.
Lalita ma'am. Yeah, she's there with
Sujata?
Lalita ma'am's IT.
Sujata, you have something to say on this?
Oh, I was the one asking that question, how to handle the emotional breakouts from the transplant coordinator's point of view. Yes, that's very interesting to add something on this aspect as well. Yes, very true. Because like every day we do kind of deal with these kind of, not exactly palliative care, yes, but to an extent, yes. And definitely we look forward to having a training module on this as well. Thank you, Dr. Seema. That was a wonderful talk.
Thank you. Thank you so much.
And I think we'll wind up here unless someone has a pressing question. I think this is a topic that we can continue to discuss. But I think each one of us should mull over what was said and see how in our own context we can at least start incorporating this concept in whatever way it can be, is what we really. Thank you so much. That was a wonderful session, and I'm so glad I met you. I'm so glad you agreed to do this, and I hope we can do some more work together in this field together.
Absolutely. Thank you, Pallavi and sir, for having me here. Thank you so much. It's a pleasure.
Bye. Bye.
Bye-bye.
Thank you all for attending.